The following podcast is part of a certified educational activity titled DLL3 Targeting Bite Therapy in Small Cell Lung Cancer, a Pharmacist's Guide to Evidence and Integration. Access the entire activity and complete the post-test at peerview.com/EJP860. Downloadable slides and practice aids are also available.
Good morning. Welcome. Welcome to our program on DLL3 Targeting Bite in Small Cell, a Pharmacist's Guide to Evidence and Integration. Our faculty today, so I'm Amanda Cass, I'm from Nashville, Tennessee, and we have Dr. Naveed Hafez from Los Angeles and Dr. Shelby Quinn from Charlotte, North Carolina. And our goals for today, we want to augment your knowledge of DLL3 T-cell engagers in small cell lung cancer, and then we want to equip you with strategies for the safe and effective use of these therapies. We want to improve your skills in team-based, patient-centric care when using these novel DLL3 T-cell engagers, and know how to educate patients and providers, optimal dosing of these agents, and manage the adverse effects. All right, so small cell accounts for about 15% of all of our lung cancers. Most common is non-small cell, but we still have about 15% being small cell. It is the most aggressive form of lung cancer, and cigarette smoking is the single biggest risk factor. The majority of patients are going to be either current or former smokers. However, you can have some patients who have either radon exposure or occupational exposure who have small cell as well. Comparatively to non-small cell lung cancer, we have a couple treatment challenges. We have a lack of targeted therapies in these patients, as well as a quick time to relapse. And in general, we have a lack of treatment options for these patients. For patients who do not have brain mets at baseline, about 80% of those patients will develop CNS metastases within 2 years. So of course, medications crossing the blood-brain barrier that work in the brain are really important for these patients. So there are a couple barriers and unmet needs and opportunities for improvement in small cell. So when we're looking at treatment advances, some of the barriers we have is these patients are smokers, so that a lot of times they will have a lot of comorbid conditions that may exclude them from trials or maybe not make them candidates for more aggressive therapy. As I said, it's the most aggressive form of lung cancer, so it has a rapid clinical course. So we may not be able to wait for patients being screened for trial. If they have to have centralized pathology review or staining, patients a lot of times don't have time to wait for that. Regular chemotherapy is easier to administer for patients. And then in general, we have a lack of understanding of the biology of small cell, and we have inadequate preclinical models to develop drugs. There are several factors that are thought to contribute to immunotherapy resistance in small cell lung cancer, including downregulation of MHC molecules and failure of antigen presentation and high intertumoral heterogeneity. And one of the strategies to bypass this is to target alternative cell surface proteins on cancer cells, and that's where DLL3 comes into play. A brief review of what our first-line treatment options for small cell lung cancer are right now. So in March 2019, we had the Empower 133 trial, which was the addition of atezolizumab to first-line chemotherapy that improved overall survival. And then we had a similar trial, the Caspian trial, which was approved in March 2020 that added durvalumab to our first-line chemotherapy. And so those patients will receive a platinum plus etoposide, plus the immunotherapy for 4 cycles, and then they will continue on immunotherapy until toxicity or progression. So this is really the first big implementation of immunotherapy in small cell. And again, we did see an improvement of overall survival, but a lot of patients still will relapse, and so we have to think about what's next for these patients. When we're looking at our second-line treatment options, NCCN has it laid out between platinum-resistant patients and platinum-sensitive patients. So platinum-resistant patients are patients who have had a chemotherapy-free interval of less than or equal to 6 months, and so that is from their last dose of platinum to the time of relapse. And then our platinum-sensitive patients are those who have had a chemotherapy-free interval of greater than 6 months. When we look at platinum sensitive, we can do clinical trials or re-challenge with platinum doublet, but we also have tarlatamab as a treatment option in these patients. And then for platinum resistant, tarlatamab is actually one of the preferred regimens for second-line treatment options. So our rationale for targeting DLL3, so DLL3 is a protein that inhibits Notch signaling, which is typically intracellular, but it's abnormally expressed on the surface of small cell lung cancer cells. There's about 85 to 94% of small cell lung cancer patients express DLL3. This is also seen sometimes in neuroendocrine tumors, which we know that small cell lung cancer is a type of neuroendocrine tumor, so that makes sense. DLL3 targeting could turn a cold tumor microenvironment into an inflamed microenvironment. So some of those patients who have progressed on immunotherapy have an immune cold tumor microenvironment. This can make it more inflammatory and being able to target these small cell lung cancer therapies with immunotherapy type treatments. And then DLL3 is also most highly expressed in those with a non-inflamed tumor microenvironment. So a lot of those patients who have progressed on immunotherapy or PD-L1 inhibitor. And as you can see here, so on the left is a normal cell staining for DLL3, and so you can see we don't see much of the brown there. And then B is a tumor being stained for DLL3, and so you can see it's highly expressed in that tumor right there. And so when we're looking over our DLL3 T-cell engager pipeline, we have a couple of different types of therapies that we're seeing. We're seeing tarlatamab, which has two antigen binding domains, but on a single peptide chain, so that's a non-IgG T-cell therapy. And then we have BI764532, which is an IgG type T-cell engager, so it has two different binding arms which bind to the CD3 and the DLL3 region. And then we have HPN328, which is a TriTAC, or has three different domains. So we have our two antigen binding domains, so CD3 and DLL3, and then we have our anti-albumin domain, which extends the half-life of these therapies. So tarlatamab is that first one here, but there are some other structures for some of these T-cell engagers that we're going to see that are coming through the pipeline. An overview of just our general mechanism of action. So what will happen is our T-cell engager will bind to both the CD3 on the T-cell as well as our tumor-associated antigen, which in our case for tarlatamab is DLL3 on the tumor cell. And when our T-cell engager binds, we're going to have recruitment of our T-cells, T-cell activation and expansion, and then subsequent cell lysis of these tumor cells by the T-cells. When we're looking at tarlatamab specifically, so this directs patients' T-cells to the cancer cells expressing DLL3. So DLL3 is our tumor-associated antigen, and it binds to both DLL3 and CD3. And so now we're going to watch a 3D animation on how tarlatamab works.
Bispecific T-cell engagers, or BiTEs, are fusion proteins that harness the power of the immune system to treat cancer. The tarlatamab molecule is a BiTE that comprises two single-chain variable fragments connected by a short, flexible linker. Tarlatamab includes a stable effector functionless Fc domain that increases its serum half-life. As a first-in-class BiTE in small cell lung cancer, tarlatamab targets delta-like ligand 3, or DLL3, which is expressed on the surface of the majority of small cell lung cancer cells, but minimally expressed or absent in healthy cells. In addition, it simultaneously engages the patient's own T-cells through the CD3 antigen. The dual binding of tarlatamab to T-cells and DLL3 expressing tumor cells brings the cells into close proximity and triggers the formation of an immunological synapse. This results in T-cell activation and ultimately the release of inflammatory cytokines, such as perforin and granzyme B, causing lysis of the DLL3 expressing cells and culminating in tumor cell apoptosis and amplification of the T-cell response.
We're going to start talking about our case here. So James is a 63-year-old man newly diagnosed with extensive stage small cell and had initial treatment with platinum etoposide plus durvalumab. Of note, he does have a good performance status. So he completed the first 4 cycles of induction chemotherapy with delays in cycles 3 and 4 due to delayed count recovery. And he was transitioned to durvalumab maintenance. However, during his routine CT restaging scan, after about 2 cycles of Q4 week maintenance durvalumab, he did have new and progressive hepatic lesions. An MRI of the brain shows a 3.7 subcentimeter parenchymal lesion consistent with metastases without edema. And his ECOG does remain good, and so he wants to explore other therapeutic options. So we're not going to touch on this case right now, but keep this case in mind because we will come back and discuss this case as we present some more data. And now I will pass it off to Naveed to go through some of the data for us.
Thank you, Amanda. Thank you all for being here so early in the morning. It's great to have an audience like this. I'm assuming we have some East Coasters here who have been up since 4 a.m. wondering what to do with themselves. So glad you could join us. I'm a early phase drug investigator, work in drug development, principally for my career, as well as focus in thoracic oncology. So I'm going to review some of the early development and early evaluation of tarlatamab, as well as some of the new agents that are in the pipeline under investigation targeting DLL3. So the first study was a phase 1 study of tarlatamab, Delphi 300. This was a classic phase 1 study evaluating the safety, tolerability, pharmacokinetics, and kind of looking for early efficacy signals for tarlatamab. There were a lot of arms on this study, looking at different dosing strategies, both different dosing schemes as well as dose levels. The criteria for the study was, a relapsed or refractory small cell lung cancer. Patients had to have 2 prior lines, so platinum exposure was required. They accepted both platinum sensitive and platinum resistant patients. You didn't have to have immunotherapy. This was an international study, so immunotherapy was not always accessible or standard in all of the countries, but you had to have at least another second line. About half the patients were exposed to prior IO, and they accepted patients ECOG 0 to 2. The study showed both promising anti-tumor activity as well as acceptable safety signal. You can see from the waterfall plot, about a little more than half the patients had some level of tumor shrinkage on study. The confirmed ORR rate was 23% on the study. This was including all dose levels. The median duration of response was 13 months, with a median overall survival in a heavily pretreated population of 13.2 months. This was very exciting data at the time, mirroring our best overall survival from our frontline studies, and this was in an advanced population. And we can see on the swimmer plots that we had, there were a lot of patients with extensive durability in their responses. It also showed an acceptable safety profile. Cytokine release syndrome was the principal AE of concern. This was primarily grade 1 and grade 2 and reversible. Treatment discontinuation because of treatment-related AEs was low at 4%. This led to the phase 2 study that ultimately led to approval that we'll review in a second. But before we do that, we'll just present some updated data. That was the initial data that was presented and led to the phase 2. Late last year, we had updated data with longer-term follow-up. This is now with a median follow-up of about 13 months for that phase 1 population. And we saw in this extended follow-up that tarlatamab demonstrated sustained clinical benefit in patients with previously treated small cell, including a long duration of response, really an unprecedented OS. The median OS in the overall population was 17 and a half months. The landmark at 12 months for overall survival was 58% of patients were alive at 12 months. And then there was a subset of patients, as you can see on these swimmers, that had sustained disease control with a long duration of time on study, including patients over a year on study. At the 10 milligram dose, which is the dose that was selected for evaluation in phase 2 and is ultimately the approved dose given once every 2 weeks, the objective response rate was 35%. The median duration of response was about 15 months, and the median overall survival was 20 months. 30% of patients had sustained disease control at that dose. One of the other really exciting things that came out of the longer-term follow-up data was the CNS data. So with tarlatamab treatment, the CNS tumor shrinkage, and they used the 30% cutoff for CNS intracranial response, occurred in 62.5% of the patients that had baseline measurable lesions in their brain. And that included a subset of patients that were responding long after their prior RT. All patients had to have treated brain mets. If they had a brain mets, they had to be treated and stable at the time of enrollment. And we see here, these graphs are maybe a little confusing, but what we're looking at on the top graph on the left is patients that had had their intracranial RT less than 50 days before enrolling. All of them had continued tumor shrinkage after being treated with tarlatamab. And then on the right, we see the patients that had had greater than 50 days, including patients that were 2 years out from their prior RT. And the majority of those patients also had tumor shrinkage, with 3 of them meeting the 30% objective response rate. The bottom graph shows that the intracranial response mirrors the systemic response that a lot of those patients were having. The data we reviewed really was exciting and led to the phase 2 study, Delphi 301. This study was looking at a very similar population, again, extended stage small cell, previous treatment with 2 or more lines, including platinum doublet. The ECOG was a little tighter. This was for ECOG 0 and 1 patients. And the first part was a dose evaluation, looking at 2 separate doses that were evaluated in the phase 1, the 10 milligram dose and the 100 milligram dose. And then that was randomized 1-to-1 to those 2 cohorts. Based on evaluation of that part, they moved into parts 2 and 3 at the 10 milligram dose. The way tarlatamab was given on the trial is the way we give it now, which is a step-up dosing. The first day on either of those arms, patients got 1 milligram, and then on day 8 and day 15, they moved to the investigational dose, either 10 or 15, and then they repeated that Q2 weeks thereafter. The primary objective was efficacy here. The endpoints were the primary endpoint was objective response rate. Secondary endpoints were duration of response, disease control, PFS, and OS. And we have updated efficacy from this study. The study was, the New England paper came out before this updated efficacy, and the FDA approval came before that, but this is the most recent data we have from this study that showed basically with that extra time, we had sustained responses, long-term survival outcomes. So the objective response rate was 40% for all patients treated at that 10 milligram dose. Okay. The median overall survival at that dose was 15.2 months. And that was similar regardless of whether patients were platinum sensitive or platinum resistant. They used kind of the European, we often use 6 months cutoff for our platinum sensitivity. Here, a lot of our European colleagues use the 3-month cutoff. They used the 3-month cutoff when they stratified this data. The efficacy in patients with brain metastasis, so this is a little confusing, a little different. We already looked at the intracranial response rate. This is the systemic response rate in patients with pre-existing tumors or not in the brain. And if you had prior brain metastasis, the objective response rate was 45%. Versus 32% in the non-brain met population. There were sustained responses in that population, as well as a nice PFS. Medium OS was not reached. It was not evaluable with the numbers they had. The most common tarlatamab-related AEs were cytokine release syndrome, pyrexia, decreased appetite, dysgeusia, and fatigue. What's important here, and this graph is highlighting, is that the first is the worst. When we treat with bispecifics, and this is common among the class, we see not just in the DLL targeting agents, but in a lot of our bispecific and cellular therapies, the side effects seem to be worse early on in the course of administration. And this is part of this reason we use step-up dosing with these drugs. So 53% of patients developed CRS, and it usually occurred in the first 3 months. It was very rare after the first 3 months of therapy, and we see that across for all of the side effects. Treatment-related AEs led to dose interruptions in 16% of patients and discontinuation in 4% of patients. This is a very similar thing we're showing here. Again, the drug becomes more tolerable over time. We see here, though, the breakdown by grade. So for CRS, we see by and large, it's all grade 1 and grade 2. There was 1 patient with grade 3 cytokine release syndrome. It occurred early in cycle 1, and there were no later occurrences of that in future treatments or cycles. And for ICANS, all the toxicities were grade 1 and 2 and reversible. So some conclusions that we can draw from the pivotal phase 2 study was, 1, tarlatamab has demonstrated notable anti-tumor activity with durable objective responses and promising survival outcomes in patients with previously treated extended stage small cell lung cancer. Tarlatamab has shown promising activity and favorable benefit risk profile in patients with previously treated small cell lung cancer and stable brain mets. And tarlatamab can cause CRS or ICANS requiring careful monitoring and management. And then so that data we just reviewed is what led to the approval of tarlatamab from the FDA. That was just about a year ago now. And this is for patients with disease progression on or after platinum-based therapy. Still a lot of clinical investigation going on with tarlatamab in different lines, in different settings, and in combinations. We have some data from Delphi 303 that has been made public, and this is looking at tarlatamab with anti-PD-L1 therapy, atezo or durva, in patients in the first line kind of maintenance setting after treatment with platinum IO. So patients start receiving the combo of tarlatamab plus their respective anti-PD-L1 within 8 weeks of completing their 4th or 6th cycle of first-line therapy. The primary endpoints for this were safety and tolerability, and based in the secondary endpoints, we're looking at early efficacy signal. And what we saw is that so far from the data we have, that this combination of tarlatamab plus anti-PD-L1 directed therapy demonstrates durable disease control with notable survival outcomes. So we have remember, this is a different population. This is the first line in the maintenance setting, so people who are responding to platinum doublet plus IO. The 6-month PFS was about 45%. The 9-month landmark PFS was just under 40%, with a 6-month overall survival of 95% and a 9-month overall survival of 89%. The median time from initiation of first-line chemo IO to the start of this first-line maintenance therapy was 3.5 months. Beginning from first-line maintenance, the median PFS was 5.6 months, and we don't have median OS data yet. We reviewed the estimates at the 9-month landmarks, and the bottom line here was that tarlatamab in combination with PD-L1 demonstrates both durable disease control, notable survival outcomes, and we'll review is also safe and tolerable to administer. In terms of treatment emergent AEs, they were very common. The vast majority of basically all the patients had some degree of treatment emergent AEs. About half were grade 3 or more. There were fatal treatment emergent AEs in 2 patients. Just under a third of patients had interrupted their tarlatamab dosing. Only 5.7% of patients discontinued dosing due to adverse events. The most common grade 3 treatment emergent AEs were hyponatremia, neutropenia, and anemia, occurring in just about 10% or less of patients. CRS, again, similar to tarlatamab monotherapy, primarily occurs in cycle 1. It was predominantly grade 1 and 2. They had 1 case of grade 3 CRS on this study. And immune effector cell-associated neurotoxicity syndrome, or ICANS, occurred in 11.4% of patients. We're talking any grade ICANS. Grade 3 was 2.3%, and there were no grade 4 ICANS doses. No DLTs were reported on this study. This is just a quick slide showing the clinical trial program that, as I alluded to, there's a lot of ongoing investigation for tarlatamab. It's being investigated in combination in second line. We reviewed the first line data that was presented in the first line maintenance setting. It's also being investigated as a combination with PD-1 in second line. There's 3 phase 3 studies going on right now. One is tarlatamab versus standard of care chemo in second line. One is tarlatamab plus durva versus durva alone, the Caspian kind of standard of care treatment for patients in first line maintenance. And there's tarlatamab after chemoradiotherapy in the limited stage small cell. As Amanda mentioned and I alluded to, tarlatamab is not the only DLL3 bispecific antibody or T-cell engager in development. It's the furthest along. It's the one with the approval, but Boehringer Ingelheim has an agent as well as Harpoon. BI 764532 is another one of these BiTEs targeting DLL3. This is showing the phase 1 schematic for the trial. This was investigated not just in small cell, but also in large cell neuroendocrine tumor, as well as extrapulmonary neuroendocrine tumors. For this study, patients had to be DLL3 positive. I didn't mention in the other studies, the Delphi studies, DLL positivity was not required, although it was exceedingly common. It was about 90% of patients, 85 to 94% of patients were positive on those studies. And this was, again, looking at different dose levels as well as different dosing scheme. We saw efficacy across all the enrolled groups in the different dose levels as well as in the different tumor types. So in the small cell lung cancer population, the overall response rate was about 26%. In the extrapulmonary neuroendocrine, they had about 19% response rate. And in the large cell neuroendocrine, there was very few patients. There was only 5 patients, 3 of which had PRs for an ORR of 60%. There was updated efficacy data presented at ESMO this last fall. And here we saw in the small cell population, the objective response rate was 18%, with a disease control rate of 36%. So there's an ongoing study right now for this Darion 8 study is a dose escalation expansion trial assessing BI 764532 plus first-line standard of care therapy in extended stage small cell. Harpoon has an agent that's being investigated, HPN 328, in patients with small cell, as well as, again, looking at other neuroendocrine tumors. This is a schematic of the phase 1 dose escalation, looking at different dosing schemas, as well as combination of the drug with atezo. They're investigating in the relapse refractory small cell setting. They're looking at other neuroendocrine tumors, again, relapse refractory setting. And we see here from this schematic that they had responses really at all dose levels, as well as all different disease types. The overall response rate across dose levels and disease types was 45%. The confirmed response rate was 31%, and the disease control rate was 36%. So from these results, as of early last year, 86 patients had received HPN 328 across the 14 dose cohorts. Just over half of those patients are small cell. 63% were small cell and 37% were other neuroendocrine tumors. Among the efficacy valuable patients, the confirmed ORR in small cell was 50%. They had 1 CR. Treatment-related AEs that occurred in greater than 10% of patients included CRS, dysgeusia, fatigue, diarrhea, nausea, vomiting, decreased appetite, decreased neutrophil count, and weight loss.
So this is the same case. Nothing's changed at this point. So a patient who, 63-year-old man, completed his initial cycles of platinum etoposide durvalumab, but then progressed after cycle 2 of maintenance with both brain and hepatic lesions. So what is the next best treatment option? Naveed, I'll start with you. What do you think the next best treatment option is for this patient?
So there's a couple things I consider for the second-line patients. I really like tarlatamab based on the data we've seen. I think the two probably three key things. One is just overall PS. I think because of the CRS early, I want a patient that's relatively performance status preserved, I guess, in really good shape to tolerate that. Two, I don't know if we really know this answer from the data, but there's this kind of hint or at least thought that CRS may be more common and more severe in patients with high burden of disease. So that actually factors into my decision-making too. In other words, if somebody has a really high burden of disease I'm worried about, I will sometimes use chemotherapy, a second-line chemotherapy like lurbinectedin or something to try to cytoreduce prior to initiating tarlatamab. And then the third thing I think about is the CNS. And if there is brain mets, then that really pushes me to tarlatamab because we have such good intracranial activity with that drug. So in this patient, with PS preserved, has a known brain met, we assume he did well because he went to maintenance therapy first, so I don't really know about the burden of disease, but I think tarlatamab is a great choice for this patient.
Shelby, do you have any other insight on what you guys would do?
One of the things that I would have to consider with tarlatamab is obviously that discussion with the patient. I mean, it's extensive monitoring and admissions, things like that. So a lot of patients aren't going to be keen to getting tarlatamab just based on that. They don't want to be at the hospital more than they need to be, especially under observation for 24 hours, which we'll discuss a little bit more during my section. But that's something I think is a really limiting step for patients. And so personally, we have very few patients who are willing to do that. So most of our patients are getting lurbinectedin. I agree, the data is great, and this patient seems like a great candidate, but are they going to be willing to do that? Maybe not.
Yeah, absolutely. And a lot of small cell lung cancer patients too can be from more rural areas, maybe not have the family support, so it can be pretty intensive. And so, Shelby, what can the pharmacist do to support the care team and the patient?
So I'll talk a lot about this as well in my section, but number one, helping develop treatment plans and protocols. We do a lot of education, not just for the patient and their caregiver, but also for the other healthcare providers, nurses who maybe have never given this medication before. What do they need to look out for while they're under observation? Things like that. Even infusion nurses, when they're giving the medication, what should I be asking or looking for? When should they contact the doctor? Also assessing concomitant medications, especially if a patient's having, for example, ICANS, and maybe we need to look, are there other medications that could be causing them to be somnolent, things like that. I even do toxicity calls with my patients just to check in and say, how are things going, in between appointments with providers, lab assessments, all those things. So we are a very important part of the care team in many aspects.
And then now Shelby will talk more about what she just talked about and some of the ways that the pharmacist can support and help manage side effects with BiTE therapy.
So we're going to keep talking about James. So James is actually going to be started on tarlatamab. However, he has developed CRS with his first dose, which is common. So we want to make sure we keep this case in mind as we go through my slides. All right, great. So we'll go into more depth about the treatment of CRS based on the grading. So we've talked a lot about tarlatamab and how pharmacists play a vital role in that. As I mentioned before, as pharmacists, we can assess patients' comorbidities, their concomitant medications, how they may affect treatment, as well as any potential drug interactions that may happen. Education is really key with this medication, especially given the adverse events, not only for the patient and caregiver, but also for our healthcare providers as well. We also have a key role in managing adverse events, whether it's developing protocols or recommending treatment options. And then we can also have a role in insurance issues. So there are many barriers to implementation of tarlatamab if you haven't already experienced them at your institution. As you can see, site of care, reimbursement, education, care coordination, and adverse event management are just a few. Each institution is going to need to revise or refine their current protocols and procedures in order to implement this medication. And as mentioned before, there are a lot of concerns about patients who may be in more rural communities and their access to this treatment, so there may be considerations of disparities for certain patients. One thing with this medication, a barrier that we have is that this medication requires significant monitoring, especially with the first 2 doses. Patients need to be observed for up to 24 hours after treatment. And so in order to get the most reimbursement, patients are admitted under observation. Essentially, this allows for outpatient reimbursement. It's a little bit more cost effective. But there are rules to that. So patients can't be admitted, they have to be admitted less than 2 midnights to be considered observation. Well, if a patient experiences an adverse event and they are longer than that, then it changes over to a hospital admission and more costly for the patient. So we mentioned about the monitoring adverse events. We talked already a lot about CRS, but I'm going to get into the little bit more nitty-gritty here. Basically, these are the main side. CRS and ICANS are the 2 side effects that really require such significant monitoring. Will be the focus of what I'm talking about in the remainder of the slides. CRS occurs in about 55% of patients, and recurrent CRS in about 24% of patients. And as you can see in the bar graph, it's most commonly happening cycle 1, day 1, and cycle 1, day 8. Hence, the monitoring required those first 2 doses for up to 24 hours. We also have ICANS, which is a little less predictable and can occur essentially at any time. ICANS occurs in roughly 9% of patients, so much lower incidence than what we see with CRS, and the median time to onset's about 30 days. So big point of education for patients because their monitoring is not going to be for 24 hours. So what do they need to be looking out for at home? What do their caregivers need to be looking out for at home? So that's a key point. And you can also see some of the other adverse events there as well. Fatigue, dysgeusia, neutropenia, those also occur a little bit later in treatment, or averaging about 30 days after the first dose. So CRS symptoms can be progressive, and they include things such as pyrexia, hypotension, fatigue, tachycardia, nausea, vomiting. And the grading is located in the table there for you, and it's also in the package insert. But basically, grading focuses on whether the patient is febrile, whether they have hypotension, are they requiring IV fluids or vasopressor therapy, as well as if they're hypoxic, are they requiring supplemental oxygen, what type of supplemental oxygen, and that all is incorporated in what their grade may be based on their symptoms. So in order to reduce the incidence and severity of CRS, they receive a step-up dosing, as well as we mentioned, the changes in monitoring. So tarlatamab is administered weekly for the first 3 doses, and we have, after that, it's every 2 weeks. Our first dose is a step-up dose. They receive 1 milligram, and then subsequent doses will be 10 milligrams. This step-up dosing is also meant to help reduce that incidence and severity of CRS. We also give pre-medications, dexamethasone prior to the first 2 doses, again, trying to lower that incidence of CRS. And we also give a liter of normal saline following tarlatamab for the first 3 doses. Now, the key with tarlatamab is that monitoring, as I mentioned. So initially, it is quite significant, which can be really impactful for patients' decisions. So for those first 2 doses, patients need to be under observation for up to 24 hours. And that's not all. After the first 24 hours, patients also are required to be within 1 hour of a hospital for the first 48 after the first 2 doses. So if you have a rural patient, they may need somewhere to stay that's closer to the hospital in order to get this treatment. Additionally, even as patients progress through treatment, the monitoring requirements decrease. But if a patient were to experience CRS or ICANS, it's going to change back to that 22 to 24-hour observation. So we'll talk a little bit more about incidences where that may happen. So this is the management of CRS based on what grading a patient has. This is also in the package insert, so I'm going to be a little bit more brief just for the sake of time. But for grade 1, it's more symptomatic treatment. Grade 2, you may add oxygen, IV fluids if a patient's hypotensive, and you may consider a dose of dexamethasone or tocilizumab at that time. And you're also going to interrupt tarlatamab until that resolves. Grade 3, similarly to grade 2, except for you may require vasopressor therapy. And at this point, you're probably going to, instead of consider DOCI and dexamethasone, you're going to recommend giving dexamethasone or tocilizumab at that time. And then grade 4, similar to grade 3, but a patient may require multiple vasopressor therapies in order to maintain pressure. And at this point, you would permanently discontinue tarlatamab. So as I mentioned, monitoring may change depending if a patient experiences CRS. So if a patient experiences grade 2 or grade 3 CRS, regardless of what dose they're at, the next planned dose you will monitor for 22 to 24 hours observation. And additionally, for grade 3, you'll also add those additional pre-medications back, so that dexamethasone prior to tarlatamab and 1 liter of normal saline following tarlatamab. So ICANS, or immune effector cell-associated neurotoxicity syndrome. This is when the T cells cross the blood-brain barrier and the inflammatory cytokines and chemokines affect the microglia, which can lead to symptoms such as confusion, seizures, disorientation, cerebral edema, and all of these are involved in the grading. But again, as I mentioned, with the timing of this, these are symptoms that would be important to educate your patient and especially their caregiver on, depending on if it's presenting later. So the onset of ICANS can be concurrent with, following the resolution of, or in the absence of CRS. So ICANS also has an assessment tool, or the ICE tool, which is used to assess patients' orientation, their recall ability, their writing skills, attention, and commands. They're able to follow commands. And this score is essentially put into the grading for ICANS. And you can see that in that grading ICANS table. So ICANS grading includes this ICE score, as well as a patient's level of consciousness, their seizure activity, and if they have edema on neuroimaging. Similarly, so the management of ICANS, this is also located in the package insert, and so for the sake of time, I'm going to be a little bit more brief going through this, but grade 1, supportive care, workup for alternative causes. So for example, if they're somnolent, making sure they're not on any other medications that could be causing that as well. Grade 2, similar to grade 1, but at this point, you might give a dose of dexamethasone or methylprednisolone if their symptoms worsen. Grade 3, similar to grade 2, but patients are going to require more intensive care, so they're going to be sent to the ICU for closer monitoring. Consider mechanical ventilation if you feel like their airway is compromised, and you will consider repeat imaging at that time. You'll also likely schedule dexamethasone treatment as well as methylprednisolone at this time as well. And then grade 4 is going to be similar to grade 3, but at this point, you're likely going to require mechanical ventilation potentially, and then treat for status epilepticus as well. And at this point, you would discontinue tarlatamab completely. And similar to CRS grade 2 and grade 3, regardless of where they're at dose-wise, their monitoring is going to increase for their next dose to that 22 to 24-hour period. So two most common medications that we give, which I've already kind of alluded to, are tocilizumab, which is an IL-6 receptor antagonist, as well as dexamethasone. In my personal experience, we use tocilizumab more often when we're treating CRS, and dexamethasone when we're treating ICANS because it can cross the blood-brain barrier. Alternatives, we can use siltuximab as an alternative to tocilizumab, and then anakinra is often used in more refractory cases. So here are some of the other adverse events. Again, not focusing too much on these, but we do have dysgeusia, which has an incidence about 30% and often treated with non-pharmacologic options such as oral hydration, oral hygiene, and nutrition. We also have neutropenia with an incidence of about 16%, but febrile neutropenia was very rare, less than 1%, but patients could receive G-CSF if they needed to, or you can just hold treatment as well. And then elevated LFTs had an incidence of about 11%, and essentially you would just continue to monitor this throughout treatment. There are other important considerations to adverse event management, which can include, as I mentioned, education for staff, patients, caregivers, protocol development in place for adverse event management, procedures, procurement of medications, such as tocilizumab, making sure that is on hand, as well as having the appropriate facilities and staff to administer the medication and conduct appropriate monitoring for patients. So now we're going to go back to patient James. So he's been initiated on tarlatamab, and he has now developed CRS with his second dose. So Naveed, how would you approach the management of CRS with this patient? Especially, I would love to know if, with grade 2, it talks about considering dexamethasone and tocilizumab. Are you quicker to pull the trigger on that when someone has grade 2?
Dexamethasone, yes. I have a fairly low threshold to use Dex. I'm not worried about it. I think, from the immune checkpoint inhibitor standpoint, I feel pretty comfortable with it as it is. I think we don't really know the impacts of Dex on these bites in terms of efficacy, but presumptively it's very low. You don't need, primed T cells for response with these drugs in terms of like antigen presentation and priming. And all patients are receiving some degree of Dex as they get these anyways. I'm not scared of using it at all in this population. For grade 2, I don't use Toci. I think, especially with what we know about CRS with these patients, that he's probably going to be okay after this cycle, and we'll be able to move forward. Again, they're being monitored. We'll watch them. If things aren't controlled with steroids, hydration, supportive care, then we can always use it. But I typically don't run to it.
Okay. Interesting, because my institution's a little bit different. Amanda, is your institution different than that? And then kind of how, as a pharmacist, are you helping the team with managing this?
Yeah, so I think it's varies case to case on patient and what the ECOG performance status is of the patient. I will say we do have a pretty low threshold for dexamethasone. I actually don't think we've administered tocilizumab yet, maybe once, so we have not administered that very often, and we've had mostly lower grade CRS. So I think the biggest thing that pharmacists can do can depend on, where they're at in the healthcare system. I'm outpatient thoracic oncology, so I send an email to the team knowing that, letting them know that a patient's getting admitted for tarlatamab. I have the CRS and ICANS management protocols in that email, have their attending CC'd on it, and I send that to not only the daytime team, but the on-call overnight physician and the overnight fellow. So I think kind of just making sure all team members are aware of how to manage these symptoms and being available for a resource is kind of how I try to handle that.
Gotcha, yeah. And I think we focused a lot on CRS, and we'll talk about ICANS, but the other thing is our infusion nurses. So after those first 2 doses, patients are still being monitored for up to 6 to 8 hours in an infusion or somewhere. So someone's watching them. They also will require this education and additionally have those protocols available if needed. So back to James. Now we're going to be talking about ICANS. So James was initiated on tarlatamab, but now he's developed grade 2 ICANS with an ICE score of 4 with mild somnolence, awakening to voice. So Amanda, how would you maybe approach management of ICANS for this patient?
Yeah, do we know what grade it is? Yeah,
grade 2.
Yeah, for this patient too, definitely at least 1 dose of dexamethasone, if not a couple doses of dexamethasone at this point. With grade 2, you're not in the ICU yet. You're not really worried about seizures yet. So definitely probably a few scheduled doses of dexamethasone to make sure that the patient's responding, maybe a little bit more than I would do for grade 2 CRS. So probably dexamethasone just a little bit more frequent dosing. Is how I would probably handle that.
Naveed, anything you would maybe do different, and then how has your pharmacist helped you manage these patients?
That's what I was going to say. I'm calling pharmacy, pharmacy and neurology. Yeah, I mean, typically, I don't want to say typically because I haven't experienced this a lot with tarlatamab. I do investigate a fair amount of bispecifics and other cellular therapies where we do see it. Aggressive steroids is what I usually do.
Yeah, same.
So we do have quite a bit of questions, so I hope we're not going to be able to get to all of them, but we should be able to answer 1 or 2. So the first question I will give to Naveed. So are there any helpful biomarkers to guide patient selection for tarlatamab or other therapies in this class?
That's a great question, and the answer so far is no. We don't know really how other biomarkers may play into this. So DLL3, as Amanda talked about, is exceedingly common in small cell and other neuroendocrine tumors. It's crucial basically for regulating differentiation of neuroendocrine tumors. So essentially all neuroendocrine tumors have it. We see it expressed when we look at path review and 85 to 95% of cases, which really means it's probably there for all of them, right? Because it is, notch signaling is required for differentiation in these tumors, and DLL3 regulates that pathway. So it's essentially all patients have that, and we saw responses in the studies, even in those few patients that were DLL3 negative, which again kind of factors into this thought that really probably most of these tumors really are still controlled by this. So how other biomarkers may play into response, we just don't know yet. Yeah.
And then we'll do one more question. After looking through the questions, it seems like hopefully some of these others may be answered kind of in the slides or within some of the other resources. So if we don't answer your question, definitely check those out. And then a question for both of you guys. We'll start with Shelby. So are you all doing any outpatient tarlatamab step-up dosing and monitoring?
We are not, no. Patients are still being, we're following the package insert and the recommendation for admission for those first 2 doses. We do struggle a lot, one, with beds. We're crammed for beds, so even our chemo admissions, we are struggling for beds. And then infusion, with that extensive monitoring for subsequent doses, especially 6 to 8 hours, we struggle a lot finding that chair time for someone to be there for that. Right now we are not doing an outpatient. I think that would really help patients be more willing to take this therapy, especially given the benefits they may have, but at this time we're not.
What about you all?
Yeah, same. It's standard for us all to admit both on the day 1 and the day dosing. And that's without problems. If people have problems, then they'll get admitted more. And I think I wouldn't feel comfortable doing it in an outpatient place now. As we said, the median time to onset of CRS is 13 hours. That's hard to watch patients that long for to determine. And then again, they're happening within, largely within 24 hours. So again, to monitor someone outpatient is tough.
Yeah, and I think, from our discussion at our institution, I know for our hematologic malignancies, they are moving more towards outpatient administration, but, they're a lot more well-versed with these therapies than we are at this point. And I know that that's been a discussion between myself and some of the other solid tumor attendings that, all of us aren't quite comfortable yet with doing that monitoring until the only other BiTE therapy that exists is in uveal melanoma, so it's not like we're using that much. So until we get more experience with this and really kind of seeing how patients respond, I agree that it's definitely best to go ahead and admit. And it looks like that is the end of time. So I'm happy to answer any questions, after down on the floor. But thank you guys for attending.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by educational funding provided by Amgen. To access all materials for this activity, visit peerview.com/EJP860.